Hello, everyone, and welcome to the Fortcast, the official podcast of Fort Healthcare. I'm your host, Dr. Michael Anderson, ear, nose, and throat physician and physician president and CEO of Fort Healthcare. On this episode of the Fortcast, I'm very excited to have our guest, Heidi Jennrich, a nurse practitioner in our pediatric department. She's been with us for quite a while, and we are going to talk today about otitis media. Thank you, Heidi, for being on today's show. And how long have you been with Fort Healthcare?
Over 15 years I've been with Pediatrics.
Well, you haven't aged a day.
I know, right? Yep.
Yeah, I've been with the organization about 20 years, so I feel like we're kind of almost at the same era. But thanks again for being on the podcast. And today I want to talk about pediatric ear infections. So, Heidi, this has got to be a big part of your practice. Being a pediatric provider you are, high volume practice, been part of the community for 15 years. I would say, in your opinion, for our listeners out there, what exactly is an ear infection?
So I think when parents come in saying ear infection, to them it means a lot of different things because there's difference between a swimmer's ear and a true otitis media. And that's a part of ear infections or ear infections to parents. But for us, there is a difference between, meaning, is it in the ear canal? That's what you typically hear about swimmer's ear. Or is it behind the eardrum and there's fluid, and that's what is typical ear infection for us. In pediatrics, ear infection is one of our bread and butter. It is the most common diagnosis that I see. The most common reason that I prescribe any antibiotics is usually for ear infections versus anything else. So it's either earaches or tummy aches is usually why you get into me pretty quick.
And that's a very important distinction. Outer ear infection, otitis externa versus otitis media. In this podcast, we'll focus on otitis media, which is the ear infection behind the eardrum. So when you see a child, when the mom calls and said, my child has ear pain, and you see an otitis media, an ear infection behind the eardrum, what are the typical symptoms that they have?
So it depends on the age, and that's also depends on how we treat it is based on age. We get calls from kids that are old enough. So in my world, they're from infant and I go to 21. So those are they kids that can talk and tell you their ear hurts? So that's a very different deal than is it kids that are nonverbal. So those are your infants, your toddlers. I mean, toddlers might say pain, but they might say pain when I ask them about their hair hurting or their toenails. So they're not always great historians when we ask them questions. So the question is, it's easy. If you're verbal and you can tell me you have ear pain, that's why you're coming in. And you can answer the other questions. Do you have anything else going on? Because as adults, we know when we get stuffy nose and cold symptoms, our ears sometimes feel plugged or hurt. So there's a difference between on how we treat them for what age they're coming in. So usually babies, plus or minus, they'll always say they're playing with their ears. And I will tell you that is not a diagnostic criteria for an ear infection for me. Plus or minus, they play with their ears because they can find them. They play with their ears because they hurt or they itch, or there's lots of different reasons they're playing with their ears. I always ask, how did they sleep the night before? So that's one of my tells on whether I'm more suspicious of true ear infection that I may need to treat is what happened last night. I gave them Tylenol, I gave them ibuprofen for the pain, but they kept waking up during the night. Those are babies and kids I'm going to see that next day.
Gotcha. And how often, Heidi, would you say, do you see cold-like symptoms with the pediatric population with ear infections? Is it pretty common or not really?
Depends on the age. So I tried to explain to parents, an ear infection is behind the eardrum. That is station tube, which Dr. Anderson, when we put myringotomy tubes, which are the tubes kids get, that is the tube that needs to drain, which goes to the back of your nose. So when you get congested and you're a baby, it's a short distance from the back of your nose to where your eardrum is. And as you grow older, we get less ear infections. Kids get less ear infections than infants. So the likelihood of what's the percentage of a baby that gets an ear infection from a cold, not all the time. There's lots of babies that aren't in daycare, right? I should specify babies that are in daycare are more likely to get more ear infections because they pick up more colds. And my plug that 8 to 10 colds is normal per year, and it will feel like back to back to back colds all winter long because we're getting back to post-pandemic. We're back to the usual colds. So the part is how often do I see it during the pandemic? I gave about 10 prescriptions over a course of 3 months for antibiotics. I can give that in 2 days, potentially, sometimes in the deep winter, super sick kids that I can see and prescribe antibiotics for ear infections several times during a day versus during pandemic, less colds, less ear infections. It was awesome.
Wow, up to 5 a day. That's a lot of ear
Uh-huh.
infections. And I just want all our listeners to know that we did not name the eustachian tube. I don't know how they came up with that name, but it's a mouthful, the eustachian tube, but it is the culprit in a lot of cases with these bouts of otitis media. So, Heidi, when you see a child with an otitis media, with an ear infection, how do you typically treat them? Can you talk a little bit about that?
So the recommendation is based on their age. If they have an ear infection under 6 months, regardless of how they're feeling, and we see fluid, we will treat that with antibiotics and they get full 10 days. From 6 months to 2, it's really based on are they really sick? So there are some times that I can wait a little bit with them, depending on how parents' comfort level is. So under the age of 2, and there's a difference when we look at eardrums for parents. What they have to understand, a true ear infection, the way I describe it, is a bulging like a donut full of what we call purulent effusion. I tell parents it's pus. Okay, you got big old white stuff back there. And there are lots of variability of how often do I see a true classic bulging ear infection versus some version of fluid behind the ear. I would say 75% of the time it's something else. There's some fluid, but it may not mean that I need to give antibiotics. And over the age of 2, most kids, if we give them time and we do pain management with them with Tylenol and ibuprofen and comfort measures, a lot of those don't need any antibiotics. So we have really gotten away from giving so many antibiotics because most of the time you might not need them. But on our babies, we pull the trigger much quicker to treat those with antibiotics.
And I think that's an important distinction to make. I think that's evolved over the last 10 to 20 years, the amount of antibiotics we use to treat otitis media, because a fair number will resolve without antibiotics. They fall under that viral otitis media. So it's important for people to understand that they may not receive antibiotics when they have an otitis media, and we may give the body a chance to heal it on their own. I think the topic of antibiotic resistance and antibiotic stewardship is so important in today's talk. So, Heidi, after you've seen a child with otitis media and you treat them or you're observing them, do you see them back, or do you just typically tell their caregiver to say, hey, just come back if you're having symptoms? Or how important does that weigh on you? How important of an issue is that?
So first ear infection is different. First ear infection, what I tell parents is in about 2 days, the cold's getting better, they're going to start to feel better. They shouldn't be running fever anymore as they finish out their cold and I treat them. Babies get treated for 10 days with antibiotics. At the end of the 10 days, they should be pretty relatively symptom free, meaning unless they pick up another cold, because absolutely, I told you they can have lots of colds back to back. So really, I don't bring those babies back in because if they start to have symptoms, they're going to be back in for me. Now, there is a difference though. If it is a baby or a kid that just had an ear infection a few weeks ago in the ER, was in our clinic, another clinic, and prescribed antibiotics in the last month, now I'm seeing them with an ear infection. My medical decision is the ear infection did not resolve, or is this a new ear infection? And that's the difference part of it. How we get to ENT, that part is there are some kids that never really get rid of the fluid. And so it's not an antibiotic issue that we chose the wrong antibiotic the first time. It's can this kid resolve it with antibiotics or is it a structural issue going on? And that's why babies get back to the station tube that who named it and whatnot. I just call it the tube. There is a connection from the tube from the back of your ear down to your nose, and it's that angle of the tube. Can it just not drain down the tube? And so kids that are getting recurrent ear infections, we just saw you, we're going to the next antibiotic, you're going to the next antibiotic again a few weeks later, then that's different. Those babies are coming back for recheck to make sure the fluid has resolved.
So, you touched on referring to ENT, Heidi. So, at what point in a child's care do you consider ENT referral, or at what point do you consider maybe this child needs myringotomy tubes?
That decision comes down to why we're bringing them back. The classic is that you've been treated 3 times, and I need to specify because some parents will say, yeah, well, this is number 3 ear infection. She had one back in June, she had one in January, and then she had one in May. Those kids are not kids that I care about that need tubes. The ones that need tubes are, it's already winter and germs. I saw them in October, they had an ear infection. They saw another provider back to me, they had an ear infection in November. 3 weeks later, we're coming back, we still have fluid. So it's the three times that fluid is not resolving, and we have changed antibiotics. So sometimes it is that we needed a different antibiotic, but there are some times that really is an eustachian tube dysfunction. The tube is not draining, so no matter what antibiotic I throw, I am not getting rid of the fluid. And I think the important part in pediatrics is, why do we care about the fluid on the ears? That affects the hearing. So on babies and our toddlers, it's the most important time that they hear really good, crisp voice so that they can really start learning the language. So if you have fluid on your ears, everything seems muffled. So the ear infection, or if they have fluid, might not bother them. They're sleeping fine, they're playing fine, but it can affect their speech development.
I just really want to echo that. It's always very rewarding when we put tubes in a child and we are able to suction out the fluid behind the ears. And then the parents come back and they tell us how their speech has progressed since the tubes have been placed. And that's just because they can finally hear. They don't have the fluid trapped behind their eardrum. And that's just always very, very rewarding. So I have to say, you do a wonderful job referring people. When I see you send people to the ENT office, I know that child's going to need a tube. I know
Yep.
you've really done your due diligence and really have just done a wonderful job telling the parents and explaining the situation and what's next in that patient's care. So I want to thank you for that. But pediatric ear infections, very, very common. They can be serious, but the vast, vast majority aren't. So it's just very important to get those checked. If you're a loved one out there, a parent or a grandparent or a caregiver, and you're worried about an ear infection, please get it checked. So, Heidi, are there any ways that parents can prevent ear infections at all? Do you ever counsel them, or do they ever say, hey, what can I do to prevent these from happening?
The big part is smoking. I mean, that's hands down has been shown. Don't smoke in the house, don't smoke around the baby, don't smoke in the car, the truck, the whatever it is. No smoking. That does increase the risk of ear infections. Unfortunately, daycare, I mean, you get more germs. Parents get real upset that their kids were sick back to back as infants and children because they were in daycare. What I tell them is, guess what? When they get to kindergarten, they have this awesome immunity and they're going to learn all that education because they're never missing school because they have great immunity. So the part is breastfeeding is protective. The other part, I think, not propping bottles. That's one of my other things, and making sure we're paying attention to them. So not propping bottles. And there's sort of weak evidence of everything else. I think one of the things that I forgot to mention, parents always ask me, how do I know they have an ear infection? And I think I only touched on it. So one of those tells that I have, if parents are like, I don't know, they're playing with their ears, all those kind of things. On babies, when they are teething, they will play with their ears. And I can guarantee if I divide their mouth in the half, if it's on the left side a tooth is coming through, they're going to play more on that left ear. The same thing on the right. And I will chalk up fever to 101 to teething. When I don't is if we're over 101, most of the time those babies need to come in. They're playing with their ears. They have wet coughs at night. When they lay down, I'm way more suspicious in running fever. So the fever, they don't want to sleep at night, yucky coughs when they lay down. They're just crabby. And sometimes you get them in the office for a well child and there's nothing wrong with them. They got raging ear infections. So the part is how the ear looks does not always correlate with how it feels in a baby. So that's hard. But the part is that there's no magic when people say, well, how do I know they have an ear infection? Ugh, I have tools at home and I can look at my kids. My kids all came in for the well childs one year when they were little, and two of them had raging ear infections, and I had no idea. I have the tool to look at home.
It can sneak up on you, but those prevention points are wonderful. And I'm really glad you mentioned the teething because obviously every child, or just about every child, goes through that teething phase and it can mimic ear infections quite often. So, Heidi, I just want to thank you again for coming onto the podcast today to talk about pediatric otitis media. It's been wonderful to have you on. I know our listeners have enjoyed this. So, thank you for coming on, Heidi.
Well, thanks for having me.
Once again, I'd like to thank Heidi Jennrich, our nurse practitioner in pediatrics, for being on this episode of the Fortcast. If you found this podcast helpful, please share it on your social channels, and please check our full podcast library on our website for other topics of interest. Thank you again for listening, and have a great day.